I can't seem to see once people have joined. So Jared, you might have to give me a little nudge when we're kind of ready to kick into it proper. But those that have joined, welcome to our second event for the PHN Insight series. We're really grateful to be joined by Professor Nicole Lee again, Tim Hilton, who heads up a big area of our work focused on kind of these partnerships and collaboration, and also joined by Gay Lemon, who we've worked with in the Brisbane and Queensland project that we'll talk through today. So I'll just jump to the next slide. Jared, we're kind of good to run through. 5 attendees. All right, cool. So I'll start by having an acknowledgement of country. In the spirit of reconciliation, we acknowledge the traditional custodians of country throughout Australia and their connection to land, sea, and community. We pay our deep respects to elders past, present, and future, and to all Aboriginal and Torres Strait Islander peoples here today. So if I could jump to the next slide, please, Tim. The purpose of these webinar sessions really came about because we wanted to, as an organisation at 360 Edge, we're really passionate about the alcohol and drug sector and passionate about improving the capability of it by providing support both to their AOD service providers, but also commissioning bodies to ensure that that commissioning is done as best as it can in order that it might help as many people as possible with these conditions that we really care about. So we decided that across different projects that we're working on, we wanted to build a forum to share experiences that we're learning across the nation around how to work with people with alcohol and drug challenges, but also how to commission services that do it and share knowledge and insights into doing it well. So this is our second session, and really open. We wanted to keep it as open a forum as we can. So we actually had feedback in the last session that we would open up to people to join at the end of the content piece, so you can come in and ask questions personally and see each other as colleagues across the sector. But if you don't feel comfortable doing that, you can also send in questions throughout the presentation, and we can answer it, or other attendees can answer it, or we'll bring it up at the end. So we're going to Nicole's going to start with a bit of an overview of the challenges in commissioning services in alcohol and other drug funding environment. Then Tim's going to jump into Queensland Service Mapping Project and the thing that we've worked with Gay and many others on this call. And then we're going to go into insights and opportunities that we've learned from it, and then we'll open up as a forum of Q&A. So we should run for about 30 minutes or so, and then we'll open up for questions if people want to stay longer. So I'll hand over to Nicole and be on the chat on the Q&A if you have any questions to pick up at the end.
Great, thanks, thanks Chris, and thanks everyone so much for coming. If you're interested in watching the previous webinar, maybe Jared might post it in the chat, the link in the chat for you. So I've been working in the alcohol and drug sector for 32 years this year, which is a slightly terrifying thought, but for as long as I remember working in the sector, funding has been a real problem. There's not enough of it for a start. So you've probably heard the statistic that across all funding sources for alcohol and drugs, there is only about half the funds required to meet the service demand. And that research was done in 2014-ish, which was nearly getting close to 10 years ago now. And things haven't changed very much in that time. The number of clients has increased substantially during that period, and the funding hasn't really had a significant boost since the creation of NIAS, which was around the same time, so National Ice Action Strategy. And you've probably heard the other statistic that the alcohol and drug sector is funded at about 1/10 of the mental health sector. And we all know how underfunded the mental health sector is. And this is despite alcohol and drugs providing services to about the same proportion of the population. So that's about 2%, in case you're wondering. So no one ever has enough money for everything, but the funding in the alcohol and drug sector is a big deal for all of these reasons. And it makes it really super important that we are really efficient with the funds that we do have, of course, while we're trying to expand those funds. But it's also not just about how much money is available. Obviously, that's important. And it's not even about what types of services are being funded. Obviously, that is important too. But the other piece that we don't often talk about is the way that services are funded and who funds them. And that makes a difference to what happens on the ground, and especially in terms of the requirements they might impose on that funding, and how that impacts on how services are delivered. So in a kind of left field example, but at one stage I was working in a clinical service in a fairly senior role. I was supervising a bunch of alcohol and drug workers. And when I first got there, and it's still the case, that the way the government funded services was, the way the government had funded the services was through episodes of care. And so there was a minimum level of episodes required for a certain dollar amount. We give you 300,000 and you give us 30 episodes or something like that. And that was negotiated every year between the funder and the service. And an episode was finished when a client met a goal, and that was reported every quarter. But clients don't follow quarterly reporting. So you might see someone for 6 months and they don't seem to be making any huge gains, and then suddenly all the balls fall into place, and then they power along. But under the episode system, you won't get paid for the first 2 quarters of work with that client. So what often happened on the ground then was that the goals were made so low that they were guaranteed to be met by the end of the reporting period, so they could tick off an episode. So I'm like, why is this person's treatment goal to turn up for treatment? That's not a treatment goal. That's like a necessary but not sufficient condition for change. So this kind of example is just shows that funding really needs to be able to reflect the complexity and the unpredictability of clinical work that happens on the ground, balanced against good client outcomes. And the clinical work should be driving the funding rather than the other way around. But at the moment, the problem is that we don't even have a handle on who funds what or what the outcomes of those funds are. And I remember when the PHNs first came into existence, when we moved from the Medicare locals to the PHN model, and then shortly after they were given the responsibility of commissioning federal government funds, there was not really a very clear framework set up to help guide where those funds went and how they interacted with existing funding structures. And I think that's probably still the case, that the link between different sources of funding is still fairly unknown. So unlike other areas of health, there's not really a good delineation between, say, what the state funds and what the federal government funds. For example, it's all kind of one swirling pool of funding that's not super coordinated. So all of that's why the work that we are going to be talking about today, which Tim's going to be going through, I think is so very important. If we can get a handle on this kind of administrative part of the funding, I think that will have a flow-on effect to the important clinical work that happens. So I will hand over to Tim. Tim's our head of systems modelling. He has a background in accounting originally. He doesn't tell many people that, but he spent more than the last decade in health services management and health services consulting. And he's going to talk about a range of kind of broad issues, but also talk about a project that we worked on just recently finished with the Queensland PHNs, and some of the processes that might help untangle some of these issues. So, thanks, Tim.
Thanks, Nicole, for that fascinating background there and in introduction. And no, thank you for bringing up my accounting background, but let's move on from that. So first slide here, I've got, I say best practice commissioning. So that's what we all strive to deliver. So we're keen to share our experiences with commissioning, and also the insights from the recent work that we've done with Queensland. So I'll be drawing on, as Nicole mentioned, over 13 years experience of commissioning in healthcare as part of the consulting work that I do, and in other sectors prior to that. And I've been on both the purchaser and provider side of commissioning, and as part of designing tenders, responding to them, doing the pricing, doing evaluating, and also I did some probity work many years ago as well. And also my background includes a lot of work around healthcare funding models and using activity data, which a lot of it focuses on the has focused on the acute health sector in hospitals specifically, where there is quite a bit of that activity data and cost data that informs revenue and funding models. I've also looked at funding models around mental health and some of the challenges of adopting some of those acute hospital type funding models in a sector like mental health, which where there's similarities with the challenges also with the AOD sector, the alcohol and drug sector. But I also know how powerful having that data can be. And also the experience with commissioning, how time consuming it can be, how expensive, how resource intensive it is, and how the outcomes of the process can last for years. So it's really important to get it right. And Queensland PHNs recognise the challenges of commissioning in the alcohol and other drug sector and the opportunities from better data and processes around this. So it did engage us to support them on that. So we share some of our experiences there. So what's unique about the alcohol and other drug funding environment? So there are multiple funders. That includes the PHNs, state governments, which is mainly the health department, but it can include other departments. So in Queensland, there was corrective services, and there was some, one of the youth departments, there was some funding that came through there as well. There's the Federal Department of Health, there's the National Indigenous Australians Agency, and other sources as well. So as a result of that, there can be inconsistent approaches to planning, commissioning, and reporting. The timing and format of commissioning can differ. Reporting frameworks can differ, including metrics, reporting frameworks, and timeframes. And this places quite a challenge on providers. We also know in the sector that data on funding, on current funding, is limited. One of the issues there is around there's no nationally accepted taxonomy for treatments or services. There's quite a few frameworks out there, but nothing where data is collected routinely on defined, really well-defined treatment and services. There is the alcohol and drug treatment services NMDS, but there's no dollar value assigned to those units of activity or cost data. So with these characteristics, there's benefit from sector-wide planning frameworks and processes. So we don't want to overlay, I did talk about mental health before, and this framework, planning framework here, does come from mental health, and we don't want to overlay mental health onto alcohol and other drugs, but there are some, this is a relatively generic framework that there can be some usefulness for AOD. And we've taken this and categorised it into four phases. And first phase is around governance and structure, and due to the multiple funders, this is really key, and something that really came through strongly in the work that we did in Queensland is engaging with, establishing those relationships with the other funders and the sector stakeholders. The next phase is around being data informed. So mapping existing services and pathways, one of the key outputs that the Queensland PHNs were seeking from us. But also on the other side, identifying the population needs, the service targets and gaps. So whilst there's another process to develop that work, those two things do need to talk to each other. So you do need that common language across them, that taxonomy, where you can compare needs and current investments to understand the gaps. So once you can do that, then you can engage together on what the priorities are as funders in the sector, and how you go about implementing that And then you go through the implementation process, and important to review that and evaluate. So from a service mapping project perspective, what do we do there? So talked about taxonomy there, a common language to describe the funding data, to break it down into what the treatment types, what's actually being purchased, what that funding is being used for. And we referred to a number of frameworks for that. We settled on a most recent state framework and adapted that with some additional categories. We designed data capture, captured templates in Excel to collect that data, identified the stakeholders, and engaged with stakeholders from other funders to complete that. And that's not an insignificant task. That's resource intensive. It does require a commitment to do it, an understanding of the framework that we're using, and also then trying to massage the data that they've got into that, so we can all start talking in a common language. And then we were able to review and analyze this mapping data, not comparing it to, we didn't have access to the needs data, which is quite valuable, but on its own, understanding where the current investments are going has quite a few insights. And we'll talk with Gai from the Queensland PHN, Brisbane North PHN, about that after this. So here are some example outputs from the work. So we've got here, we can actually just get a sense of the proportions of funding from each of the funders. We can then start to categorize it by treatment type. You see there our taxonomy there, we got the 6 categories plus another. And I talked about the challenges of massaging the data into those categories. And at this stage, some of it does have to go into other for some funders. And that's okay. It's the start of a process that the funders can work together with the sector to categorize that better and inform themselves more. We also looked at some commissioning process insights. So we talked a lot about planning so far and establishing those relationships and the governance and frameworks, being data informed, engaging with the sector and other related sectors as well. And that's important, especially around a separate framework for the Aboriginal and Torres Strait Islander population, recognising that the service model is a holistic service model and needs to be culturally informed. From a purchasing perspective, there's some challenges there around recalibration or shifting funding around as part of commissioning process that needs to be acknowledged and recognised and informed by proper planning with other funders and with the sector about what some of the challenges are from potentially moving money around. Ideally, we've got more money that we can put into priority areas, but without that, if there is a desire to move money around, well, there's some risks around that, because it can challenge program viability where some programs are interconnected. And that can also be an impact with short-term contracts as well. Need to have careful transition in and out plans around those if they get defunded, as it can affect other programs. Manage the contract management side of commissioning, the reporting side of things there, making sure that reporting is evaluating the metrics, the reporting frameworks, the timeframes of reporting. They all add to the conversation around how to do things better and can inform future commissioning processes as well. And then continually evaluating and informing future planning and commissioning processes. So some of the core PHN capabilities around that are seen as valuable, having that local knowledge and being responsive to local needs, and also having that AOD knowledge and being able to disseminate that across the sector and across other sectors as well, and advocating for the sector, more funding, better ways of engaging with the sector. Now, that's a role that the PHNs have and can play. And contract managers are an important link between the PHNs and the sector stakeholders there. There's also a bit of talk about co-commissioning, and it's important first to define co-commissioning. So It can mean many things across the spectrum or these phases of commissioning. So working together on planning, that's important. Working together on purchasing, that's also important. Maybe around management, having co-commissioning there and having another funder commission or manage the contract on your behalf, maybe starts to lose some of that local knowledge and responsiveness. So what are the opportunities? Well, establishing partnerships with other funders, getting the conversation going, working together, making sure there's no duplication of tasks, and the tasks that each other's doing is being able to be used across the funders and in value with the sector. Establishing consistency in taxonomies and reporting, trying to have one way of doing things, a best practice way of doing things, not multiple. Being data informed, evaluating and enhancing along the way. I'll throw over back to Chris.
Thanks, Tim. And yeah, really appreciate the work that you've done. So what I would like to do now is encourage you all, if there's specific questions about the project or process or things that are more relevant to your particular PHN area or different, we'd love to open up for discussion. So please feel free to, if you put your hand up, press that little raise your hand button down the bottom. We'll actually invite you into this forum, or feel free to, in the Q&A box or chat box, just pop in a question there. But in the meantime, whilst we're waiting for people to come in with some thoughts, we have a few prepared questions for you, Gai. So, perhaps you could tell us from the PHN's perspective, what really drove you to commission this kind of work or engage in this kind of work?
Thanks, Chris, and thanks 360 Edge for giving me the opportunity to be part of this. It was a great process to have you involved with, and so really what we've been looking at for a while was the fact that we really needed to pull together consistent statewide approaches to how we plan and report, particularly the reporting, because we know that that's hugely problematic for a number of our agencies that are spread right across the state, and a number of PHNs may fund them. So we wanted to make sure that we had some consistency in how we approach their reporting processes. But we also wanted to see where there might have been potential to do some cross-regional work as well, because as we know, people are very transient in this space, both as service users and also as workers, and it's important to appreciate that boundaries are really arbitrary lines on a map. And so being able to work across sectors is really important. We also wanted to know what the current investments were. And as I think Tim mentioned in his speech there, that it's important to gain a much broader sense of who's investing in what, and also getting some insight into the types of treatment services that are provided, because that too is a bit of an unknown. And we discovered, for example, that PHNs do a lot of psychosocial funding as a result of this project, which was fantastic. And also obviously being able to utilise your good selves, knowing that you had great AOD sector experience, and particularly being able to draw in the other funders as well, because that can sometimes be a tricky prospect when you're a funder yourself and trying to work out those particular nuances.
And what were some of the, I guess, insights from the work that will help inform kind of future planning, or challenges that you see that need to be addressed that might be unique specifically to PHNs?
Yeah, well, we are reasonably new players in this space, and as a consequence are relatively unknown. So I know certainly from most PHN's perspectives, being able to develop really good stakeholder relationships is key, and also having that connectivity between the PHNs themselves and being able to speak across those regions. So having those connections is really important. Having good relationships with your key stakeholders, including other funders and also the peak bodies like Quake and QNADA, is vital, because we're all in this together and we're trying to do our best to make sure that this sector is able to function as well as it can, but also to do that advocacy up, as Nicole spoke about. We really do need to be making waves, I think, about more funding to come into this sector, because yeah, they're doing a lot of work, and a lot of work that could be done in mental health is being parcelled off, that in our experience, parcelled off over into the AOD space without any additional funding. And so really it's about equity in terms of funding. Um, the other learnings, I guess, were just the amount of effort that's required to talk across all those funders and the sector itself in terms of like the taxonomy. So finding that common taxonomy, that's a big task ahead of us. But people are really willing. We've already spoken with Queensland Health, and they're super willing to speak around that and how we can navigate, negotiate that. So that's brilliant. And being able to get what data is available as well, and good quality data, being able to use that data, it's made us also realise just how much more work is needed. The upside of that is, having spoken recently with, as I mentioned, Queensland Health, but also the Department of Health, and soon to also talk with the Queensland Corrective Services and the National Indigenous Australians Agency. What we're hearing is that funders are super keen to work in this space, and they're grateful that PHNs have taken this initiative, because it's something that's been needed for a long time, but either due to capacity or wherewithal, other funders haven't been able to take this on board. And so the fact that we've taken this first initial step has really offered an opportunity there in terms of where we go forward from here. So yeah, and I guess there's things around finding out the sorts of services that we're all funding. We knew that reporting was a bit tricky across all of us, because we have such a variety of reporting styles and approaches and regularity. So, for example, we here at Brisbane North do 6 monthly reports, other agencies do quarterly reports, and for a time there were some PHNs that were requesting monthly reports. And part of that's tied to the commissioning process and trusting what it is to put that money out into a sector that PHNs have had very little experience with. And so it's a learning experience for us as well about how we can collaborate between ourselves and with other funders, and, as I said, the peaks.
There's a question here in the chat which I think starts to talk to what you were just talking through, and it says interested in strategies that support commissioning and procurement, and encourages collaboration and integration. In Victoria, we had competitive tendering through state funding for years, and this had quite an impact on orgs wanting to work together, or feeling if they do work together, there's equity in the relationship. Perhaps, what are your sort of top tips on doing that well? Like, how do you foster collaboration in a competitive environment, or approach that in an effective way?
Well, I could be very facetious and say, get a very conservative government that comes in and puts the funding for a range of agencies, and then that will naturally create an alignment when a much more free-thinking and forward-thinking government comes in. Because I think Queensland is in a unique situation with regard. Well, I don't think it's unique, to be honest, but we've often had a fairly high level of conservatism in this state. And the one thing that often happens with conservatism is that it gives sectors like ours, where we are working with populations that are quite marginal and engaged in activities that fairly conservative governments find tricky to deal with at best. What it does is it gives us a common force to push up against, and I think that creates a cohesion. But certainly, harking back to my previous facetious comment, but where there was significant cuts under a former Liberal National government here some years ago, it created a need within the sector to work together. And I have to say that particularly the non-government sector and the peaks work exceptionally well together, I believe, here in Queensland. And there seems to be a better understanding between the government agencies as well as the sector now. There's been a lot of work done, a lot of advocacy that's been done by QNATA, for example. And I think that that's really helped. I also am a great believer in good relationship building. I find that having good connections with my providers and being able to truly hear what they're saying, particularly when they've got very specific needs, that helps. And if I'm able then to create bridges between either services or regions or the different sectors, I see that as a facilitating role that we can possibly take on board at PHN. It depends very much on the PHN as well, because I know that we all operate in very different ways, and there isn't a single guiding force that says that thou art PN, thou art act this way or have this guideline. There's no 10 commandments. So if that was a Victorian question, I'm really interested in that, because my understanding was that Victoria was quite good at drawing together their sector down there. So yeah, I don't know. Maybe other people have got a good response to that question.
Thank
Not
you,
sure
Kate.
that
And
helped,
no, definitely. We're at our half an hour mark. So feel free, if you haven't the time to jump off. And those that are leaving, we will send out a survey that will go to you. So we really want you to share ideas or things or people you want to hear from that will be of value to AOD work in the PHN environment. For those that can stick around, we'll just keep chatting for another 15 minutes or so, but feel free to ask any questions in there. We have another one I'll get to in a sec. Everyone's a little shy. No one wants to come up on stage as yet. So maybe this one didn't work. But yeah, feel free to put in questions, and I'd love one or two of you to come up and share your experience as well by clicking the raise hand. We have a question here to you again, Gay. Was there an agreement reached with other funders on particular activities that would be prioritised or only funded by the PHNs?
As a result of this project, no, it's very, at this point in time, we're still working with funders, providing feedback and really speaking to them about where to from here. So at the moment, no, we haven't fully agreed on anything in particular. Having said that, I know that Queensland Health is particularly interested in looking at the taxonomy and also in looking at reporting processes, and are super keen to get those happening ASAP, which is wonderful to hear. And we need to do a lot more work with Queensland Health, because I think, as Tim preempted, they have a particular planning tool that would be vital in terms of marrying with the work that we've done here in this particular project to get a much better sense of where the gaps and needs are. And so it's great that we've got this good progressive relationship now with our state health department.
Yeah, amazing, and I'm sure hard fought as well to get there. I've got Alan. You've joined us on stage. Welcome to the panelist zone. I'm not sure if you have a question or you're just a brave soul that's willing to come up here. Oh, we're not getting any sound from you as yet, but I think you're off mute, so you might have a question.
Hi, Chris, and
hey,
everyone,
mate.
And Nicole as well. Good to touch base with you guys again. Just wanted to quickly share with you from an Adelaide PHN perspective what we did back in 2020, and I can't claim any responsibility for this because it was more before my time, but what we did was we went through a recommissioning process, recognising what was said at the beginning by both Tim and Nicole in relation to where PHNs were initially starting from when they got into the commissioning space. And so we recognised a few things, one of which was that when we were doing commissioning, we didn't have a framework on which to base that on. We had a commissioning framework, but from an AOD perspective, we didn't have a treatment or quality framework. So taking on board what had been developed nationally by the peaks in consultation with the department was the National Quality and Treatment Framework. And so Adelaide PHN developed its own AOD treatment and quality framework, looking at a couple of things. One, looking at what could be used, which could be used then as a basis for commissioning services from going forward, but also once services were commissioned, providing them with a basis upon which to deliver their services. So what sorts of intervention strategies, what sorts of priority population groups, and the strategy very much does focus, or the framework does very much focus on priority population groups within the Adelaide PHN region. So we identified a number of key priority population groups. We then commissioned to address the needs of those key, priority population groups, and the services that we have funded since the 1st of July 2021 are targeting their services towards those priority population groups. So it's not providing services on a geographical location within the region, it's providing services across the region to address the needs of those priority populations. So that was a key development for us, and I think that's certainly, with me starting here in 2021, that certainly helped me get my head around how the PHN was functioning and how we were commissioning in it. And it seems to have worked quite well in terms of when it was developed, the framework was developed, it was developed in consultation with the peak body here, Sanders, with DASA, the state government body, but also other key stakeholders as well. The other thing that I was interested in, particularly from your presentation, Tim, was the end cycle of the commissioning process, where post implementation and review, and I did write a note down where you're talking about the reviewing process. And one of the things that, again, from a PHN perspective, that I don't think across the board, and I could be wrong, and I'm happy to stand corrected, is that we haven't certainly evaluated what we're doing, but we haven't evaluated the programs either. And so we're currently developing an evaluation framework. We're focusing much more on evaluation and evaluation outcomes. To that end, what we've done here too in 2021 was we did two things. We developed a standardised data reporting system for all our providers, so that rather than having providers, they could still use their own client management systems, but we gave them one process by which they could report the data back to us. But we also mandated in their schedules the use of outcome measures. And so the two outcome measures that we included were the ATOP, so the Australian Treatment Outcomes Profile. And then because we recognise that that hasn't been basically culturally approved for cultural, it's not culturally appropriate. We also, in working with our providers in the Aboriginal and Torres Strait Islander space, we also mandated the ADOM, which is the Alcohol and Drug Outcomes Measure, which was developed in New Zealand and which has been ratified for cultural appropriateness, particularly by useful Maori. And I know that a number of ARCHOs in Australia have adopted that, and certainly some of the providers here were adopting that outcome measure. So it's still early days yet for us, because we're only 6 months into the current funding cycle. And the other thing we did with the funding was, when we went out for recommissioning in 2020, 2021, we implemented 2-year funding contracts rather than 12-month funding contracts, to give that greater certainty and also longevity of programs as well. So I thought I'd just share all of that with you.
Thank you, Alan. And yeah, I mean, this is exactly the kind of insights we'd love to see come through on these forums, and for people across the PHN network to connect and meet each other, and also I'm sure Gai and Alan have if there's questions, a lot of people are just starting new in the roles in AOD, and there's a lot of churn, so there's people with a lot of really great experience to talk to. So yeah, thanks for sharing that, Alan and Gai. I have a question. If there's feel free to pop any questions in there. Tim, what was the process of getting the data like? I mean, what was the actual methodology in the project that you went through? Like, how many people did you talk to? Was it difficult? What were some of the kind of insights from the methodology of building that structure like?
Yeah, it is challenging. It is. I mean, first you've got to identify you've got to engage the funders into the process first and foremost, and then you've got to ensure there's someone that can do the work. So that's critical. From our perspective of designing the collection template, once the key challenge there was around the taxonomy. How do we ask the stakeholders to report, describe their activities? So quite a bit of work went into that. And then there's we developed a guide in terms of collecting the template, but there's obviously challenges along the way. There's submissions and then checking and reworks. So there's quite a bit of back and forth. So you do need to be stakeholders going through these processes. You do need to be prepared. You do need to set aside resources to deliver this. But it is, as Gay's mentioned and Alan's touched upon as well, it's so important to have that data, have those insights that can inform what are long-term commissioning. Alan talked about 2 years. That you want to get it right as much as possible.
Amazing. So I think we're actually good. Might wrap it up there unless there's any other final questions from any of the attendees. We've still got 18 people still out of a lot of, so there's a lot of people still very interested in it. What I'd really love to thank Gay for joining us, Nicole, Tim, and the 360 team for pulling this together. We'll send out a survey, and really we'd love to do this series every bi-monthly or something like that, and focus on really pressing critical challenges that people working in PHNs have. So please feel free to send through some queries there. We have a final question here we might kind of end on. We see here, in rural and remote areas, it seems perhaps more important than in urban areas, there are strong and formalized mechanisms for co-commissioning and collaborative operations across primary, archo, tertiary health services, with hospital services often playing a dominant role in the primary AOD health care in small remote communities, and therefore the access to quality and patient journey experience of AOD and other healthcare. A bit of a challenge from Alistair. Maybe Nicole, you might have a perspective on that. Throwing you in the deep end there.
Yeah, thanks. The only thing I have to say is to agree with Alistair, and that in the rural and regional areas that we've worked with, the situation's quite different, because often there's just one alcohol and drug worker and a mental health worker, and they're situated in a hospital, and they all have to work together to kind of sort it out. And there are fewer supports around them and fewer formal mechanisms than even in the more urban areas. And so in some ways it is kind of easier because it's smaller, and in other ways it's much more complex because there are fewer supports around. I think that's we need to think about the special needs of rural and remote areas particularly. I think that have additional issues and problems to solve on top of the things that everybody has.
Thanks, Nicole. And Alistair said there wasn't a question though. So.
Okay, I agree with you, Alistair.
Yeah.
Comment.
Yeah,
I'll make a comment back.
Started with that, so that's great. Well, great. Well, thank you everyone for joining us today. It's really heartening to put this on and have it so well attended. So yeah, we really appreciate you giving us your time and the great work you do across your communities. It's certainly difficult work, but important work. So thanks to your service, and we look forward to seeing you at the next event.